Hi everyone, and welcome to the Liverpool School of Tropical Medicine in Conversation podcast series, where we explore cutting-edge research, global health challenges, and inspiring stories from experts working to improve health worldwide. I'm Dr Kerry Millington, a Senior Research and Policy Associate here at the Liverpool School, and today we are joined by two early career researchers who will share their experiences working on a global health research programme called LIGHT. Funded by UK Aid, LIGHT aims to improve access to care for people with tuberculosis, especially in urban settings, by understanding and addressing gender and social barriers to health. Later in the episode, we'll also hear from another guest, an LSTM alumnus, who will reflect on how the programme connects with global efforts to end tuberculosis. I've had the privilege of working with all three of our guests today, but first, let me introduce Jasper and Ebuka. Dr. Jasper Nidoi, a Ugandan-trained medical doctor and health economist with over 5 years' experience in clinical trials and health systems research. Today, she will share insights from her doctoral research on improving access to tuberculosis care services among men with TB in peri-urban Uganda, known as the IGNITE study. Ebuka is a Nigerian-trained medical doctor and public health researcher with practical experience in TB surveillance and COVID-19 response. Today, he will share his insights from his doctoral research on the development and evaluation of a gender-responsive TB interventions in Nigerian communities, known as the Daston study. So welcome, Jasper and Ebuka. Let's start with a bit about you. Can you each tell us a bit about your background and what led you to be involved with the LIGHT research programme? Jasper, over to you first.
Thank you, Kerry, for that very wonderful introduction. And I think it's the salient features that are just missing in there. And part of my training in health economics really introduced me to equity and social determinants of health and how these really affect health outcomes. And before I joined the LIGHT project, I was involved in studies that looked at the impact of social determinants of health and tuberculosis health outcomes. And when LIGHT came along, my interest was already piqued in this area. And LIGHT focuses on one social determinant of health, gender. And in Uganda, we see that TB is really, really gendered. The burden of TB is higher among men compared to women. Estimates put it as high as 1 man with TB to 4 men with TB. And also men are missed out by routine care services. So LIGHT came at a time when I was looking to further on my studies, gain more expertise in social determinants of health. And it presented a unique opportunity to gain expertise in this area.
Thanks, Jasper. I'm looking forward to exploring that further. Ebuka, introduce yourself.
Thank you, Kerry, and thanks, Jasper. After I became a medical doctor, I worked clinically for about 5 years before I sort of switched into public health. Part of the reason was that I felt the need to intervene for my patients, the people I was seeing in HIV and TB clinics, at a bit of a higher level, at a more upstream level. And whilst in public health, I happen to have worked for the WHO in Nigeria as a TB surveillance officer. This is when Nigeria was pushing towards active processes of finding the people at risk of TB in communities. And I quickly observed within these outreaches that the attendance to the outreaches seemed to have been dominated by women. In other words, if you come to the outreach ground, most of the attendees will be women, depending on how you've planned the outreach anyway. But most of the TB we identified, the people diagnosed with TB at the end, would come from the few men that sort of came around to the outreaches. And I observed this recurrently. This was around 2019, 2020. And I actually submitted an abstract to the Union Conference that should have held in Seville. I titled it, "Where Are the Men?" And I described what I was finding in the field. So I was already sort of thinking around these questions. Where are the men? How do we reach them? Because also we had seen some of the evidence from our prevalence survey in Nigeria, how that men not only dominated the TB burden, but also had lengthier delays enriching care with onward transmission implications within the household. So when light came along, I think it came at the right time for me personally, because it presented opportunity to then wrestle with a question I'd been dealing with a bit more in depth, and give me protected time over 3 to 4 years to sort of go deeper into this issue. So I really, even though I missed the opportunity to travel to Seville and be looking forward to that city, having read The Alchemist, but the virtual version of the Union provided the opportunity to share findings, which then snowballed into my applying for Light and becoming part of the wonderful research and network we've built in the past 3 to 4 years.
Thanks, Ebuka, and I hope you get to Seville one day. They've both given us a really lovely intro of the timing, how that was for the Light programme to offer the opportunities to do some research in an area you'd identified on were the men. Can you tell us a little bit more on the Light programme, what research you did, the key findings that you have, and importantly, what change this has led to both on the Ignite and the Destin studies?
So for the Ignite study, we focused on public healthcare facilities. As Ebuka has mentioned, men are missing in communities, and it's the same in public healthcare facilities. We see more women, and there's more TB among men. So we held formative discussions with TB survivors, healthcare workers, policymakers, and researchers to try to co-create solutions that would bridge this gap. And we came up with 3 key things. First, we noticed that the healthcare basket offered to men is not appealing, and male-friendly services are really lacking in public healthcare facilities. So we developed a male-friendly services package that incorporated screening for TB with HIV, diabetes, and hypertension. And we hope this would be a pull factor to draw men into healthcare facilities. Secondly, about 60% or plus of the healthcare workforce is female, and part of our formative research showed that sometimes men would prefer to interact with men. So we introduced male corners, in which a male champion who was a TB survivor would interact with men, provide health education, counseling, share his TB journey, and try to encourage more men to access TB care services. We also extended the working hours from about 4 p.m. to 6:30 p.m. because part of our formative work found that masculinity tendencies and the role that men have in society to provide really leads them to prioritize work over healthcare seeking. So we extended working hours up to 6:30 to offer flexibility. Secondly, we rolled out a stamp that was developed by the National TB and Leprosy Program, but really wasn't in use, to improve screening at all service delivery points. We hoped that this stamp would enable screening to be done in a routine fashion, and also the healthcare workers would be able to track patients who have been screened or not. So the stamp was just a checklist of the 4 cardinal symptoms of TB, and this would go on the patient's record, enabling subsequent workers who see this patient to make they've been screened for TB and what was the outcome of that screening. Lastly, we introduced educational material, and that was distributed both in the facility and in the communities to increase awareness about TB and also increase self-referrals to the healthcare facility for TB screening. So we implemented this intervention from July to December 2023 in 2 health facilities in Uganda. And what we observed was a 51% increase in TB notifications overall. But the increase in notifications was higher among men compared to women, and men had 50% higher notifications compared to women. So what we saw from the intervention was that the intervention focusing on men, was able to increase notifications among men significantly without negatively impacting notifications among women. And this is very important because some of the questions that we get when we talk about gender-sensitive care is, why not improve care for all? And if we improve care for all, we'll still not bridge the gap that men have. So the fact that we were able to observe impact in our target intervention without negatively affecting other groups really builds the case for having gender-sensitive approaches for TB care in Uganda.
Thanks, Jasper. And And it's really phenomenal finding that increase in notifications among men. But also good to hear that, there weren't any negative effects on women being notified for TB disease, but highlights the need for tailored strategies. Ebuka, tell us a little bit about your research on the Destin study.
It's really complementary, the Ignite and the Destin. I think the way light was really clearly thought through. So whilst the Ignite worked in public hospitals, the Destin study in Nigeria worked within communities. If you think of the cascade of care and people's journeys, it starts in the communities and then hoping to end in the communities, but through the health facilities. So I think the two studies complement each other in that sense. And in the Destin study, we did three things. We explored, we co-created, and then we evaluated. I, as the researcher, led the exploration. The co-creation was a collaborative effort, whilst the community led the evaluation. During the exploration, we found a few important things. We sought to know what the issues were with men and care as far as Nigeria was concerned. And we did a variety of things. We conducted a scoping review to know what people had done in other parts of the world. The summary is precious little in terms of gender-responsive TB interventions. There were a few shining examples. I think I'm happy to report that Mohammed, who is on this call, was one of the shining lights from many, many years ago. And it was so good that he had thought about it. But there were just precious few examples from the published literature in TB. But we also asked men in our local areas what their issues were with reaching care. And it did come out clearly that TB information did not reach men as we had hoped it would reach them. Is it that we were channeling information through channels that men didn't really trust, or the language of transmission was an issue, or men lacked examples that were men, as Jasper had mentioned earlier. And then stigma was also an important issue men complained of. And there are so many exemplar statements in some of the quotes. We had a man, for example, who told us that everything he hears on radio, he considers it as government propaganda. And this is, stemming from experiences from the COVID-19 pandemic, where there were lots of infodemics flying around the airspace, and men had misinterpreted and misunderstood a lot of that information. So this affected tuberculosis, communication. And other things we found in our exploration was the challenges of informal work. And because the survival pressure is very high in peri-urban settings, many of the men we found were engaged in informal work. And the unprotected labor and, high levels of underemployment and just the pressure to keep providing for the family was high and became a barrier to seeking care for something considered just considered not very important. So armed with these findings from our exploration, we then sat down together with stakeholders in Nigeria. This included TB program managers at all levels, healthcare workers, TB champions, survivors and advocates, groups of men in the communities, policymakers. We sat down and asked ourselves, what will become for our context a gender-responsive care that can help to overcome these barriers we'd already identified? And, we went through cycles of Delphi and ultimately an in-person participatory workshop in Ugwu, Nigeria, in Southeast, where we then agreed on a package of interventions. It was this intervention that a local TB action group called the LTAG. LTAG is a community group. There's sort of an understanding that men have a poor health-seeking behavior. And this was one of the things that we sought to challenge. So the LTAG was led by men. It was a group of like 12 people in each community. And of that 12, 7 were men, 5 were women in one community. In the other, 8 were men, 4 were women. So it was very much men-led, and they were to conduct the activities we agreed on in their community. So this was entirely community-led. And they implemented targeted awareness creation and anti-stigma messaging within the communities. They went from public address system-based awareness creation to sort of small group meeting, in-depth, community engagement meetings where community members could then ask questions. Can I truly marry from a family where someone has had TB? And they will bust that myth. And we leveraged the community information systems. Keke Napep drivers, this is the popular tricycle in inner city transport in Nigeria. Tricycles originally from India, I think. So we engage the drivers, we engage market women, we engage religious leaders in the mosques, in the churches, local authority figures to lead these campaigns. In other words, you could say the rumor mill of the community, we hijacked it in a sense, but this time to spread the good communication. And we found that at the end of 6 months of intervention, TB knowledge dramatically improved in our intervention areas compared to the control area. But secondly, and in my opinion even more important, TB-related stigma really, really declined in our community. And to think that these activities were entirely community-led, part of the key things they did was to translate all the TB information into their local languages, change the kind of pictures we put on the posters, have repeated engagements, leveraging social spaces where men gather, as well as religious meetings and chief palaces, in majalisas. These are normalized places where people meet in our context. And we also found that the intervention was highly acceptable and also feasible. I think these were really important, given that in the context of global funding cuts, we need alternatives that can be embedded within trusted community systems, not just for TB, but actually for the health system at large.
You both describe beautifully why we really must put the person at the centre of care. And I wonder if, Ebuka, I just wanted to just quickly ask you to explain a little bit further. You mentioned the Delphi method. What is that?
The Delphi is one of the consensus building methodologies that is used commonly in health research and in fact in other kinds of research. It's been used to set curriculums, it's used to agree on guidelines, and before sort of the advent of the grade methodology, WHO and other guideline drafting organizations used the Delphi a lot. We implemented it by sending anonymized questionnaires to participants where they provided written answers, copious, sections of text on each question we asked them. We asked them, looking at this list of interventions we found in our scoping review, to what extent do you think they can be gender responsive? And the responders responded with large sections of text, and we analyzed them using framework thematic analysis. Afterwards, we reduced that long list of 17 interventions to 9, following the responses from the first round. And we then recycled a second round of Delphi questionnaires to the participants. And they provided further but refined comments and sort of put the interventions in packages, considering how synergistic they could be with each other. And this was then what we took to the in-person workshop. So we had 2 rounds of Delphi, anonymized, individualized written questionnaires to stakeholders, and then 1 round of in-person participatory workshop.
So gender and equity are really central to the tuberculosis response, and I think more broadly as we tackle infectious diseases, and I'm sure Mohammed will touch on that later. I just want to now turn away from your research and think about you both as early career researchers. What have been the biggest opportunities and challenges for you during the LIGHT program?
It's one of the biggest challenges is putting forward gender-specific approaches, particularly those that focus on men. I think the global trend, and this is not to pit men against women, but I think against the, women emancipation campaigns, trying to achieve equity in areas of education, control, autonomy, control over household income, and all of these other areas, women are historically more marginalized. But when we look at certain areas, like TB, for example, men are being left behind. So one of the greatest challenges was putting forward or selling the idea of introducing gender-specific approaches for men, even if it's known that men have a greater burden. There was pushback and there were perceptions that we should improve care for all. And when we look at some of the barriers that cut across, let's say long waiting times at healthcare facilities, this is gendered, even if both men and women face the long waiting times at the healthcare facilities. We'll find that in a setting like Uganda, a woman is able to benefit more from the healthcare services. So even if she waits for a longer time, she'll benefit from antenatal services, immunization services, and in the end, their satisfaction levels might be higher. But when we look at the men, they want to come to a health facility, get treatment real fast, and go to work. And this might also apply to urban women. So one of the challenges in doing this work was trying to emphasize the need for gender-specific approaches and how this can really help men bridge the gap and access TB care services more. Fortunately, at the time we started this study, Stop TB was doing community rights and gender assessments in countries, and this included Uganda. And in Uganda, I was able to participate in the first gender and key populations assessment. And this document provided a foundation, to on which Light was able to build its case and try to engage various policymakers to see the need for gender-specific approaches. Right now, we are developing the National Strategic Plan for 2025 all the way up to 2030, and the progress that Light has been able to make is evident. In the community rights and gender strategic objective, we are seeing gender-specific approaches that focus on men. We are seeing the introduction of male action groups, trying to formalize them within the National Strategic Plan structure. Right now, Uganda has a CAST campaign, which stands for Community Awareness, Sensitization and Testing and Treatment Strategy, in which we go door to door within communities to try to screen people for TB, collect sputum samples, take them to health facilities. If you're diagnosed with TB, initiate your treatment. If you qualify for TB preventative therapy. And within this, we're also seeing strategies coming out that would try to focus on areas where men can be found, because in the health facilities they are lacking, but where in the communities can we find these men? So the progress that has been made from where we began, where there was a little bit of resistance or lack of awareness for the need for gender-sensitive strategies, to right now, gender featuring in the National Strategic Plan and gender trying to introduce areas in which we can focus on men, is a huge achievement of the Light program.
I think that certainly is, Jasper, and thanks so much for placing that within the broader context. And it's great to see that change. I wonder if we focus a little bit on you. How have you changed throughout your PhD and your ideas of your future?
So as we mentioned earlier, my focus has been on my research interest actually is in applying health economics and these health economic techniques. So through this work, it's analysis that is still ongoing. I've been able to have first-hand experience collecting patient-related cost data, collecting data in health systems, and analyzing this to see how cost-effective such interventions can be. And this is a unique opportunity because, as I've mentioned earlier, Ignite has several components. So hosting a very complex intervention with multiple components, healthcare workers, community arms, involving several people within the healthcare workforce has really been a huge learning experience. And this has really fostered development of skills in this area, and also just broadly thinking about stakeholder engagement, because through this program, I've been able to engage more closely with various stakeholders working at the National TB and Leprosy program. So that has been key. And also mentorship. Mentorship has been a very strong area within the LIGHT consortium. We were paired with we had a Uganda country advisory group and also paired with external advisors, and through interactions with them and, questions that I have received from my work. This has really been a very good opportunity for me.
Thanks, Jasper. And I'm looking forward to picking up on that mentorship aspect that you mentioned with Mohammed. Ebuka, tell us about your reflections of your PhD journey.
I promise we've not shared notes, myself and Jasper, but a lot of similarities, starting from her key challenge, which is the conceptual blockade that I experienced when I first started this PhD. There seemed to have been a conflation of the term gender in in the public health space or even in global health literature, as if gender is a synonym for women and girls. It's interesting because there's a Ministry of Women Affairs in Nigeria. I had to engage them as part of my stakeholders for this research. And I was surprised because when I got to the ministry, 90% of the staff were men. I was like, come on, let's be sincere with our name at least. Other countries have Ministry of Gender Affairs. But they were also worried why I wasn't focusing on women. And even within the TB space, a lot of program people within the TB space were, in a sense, unaware even of the epidemiology of gender in TB. And the program, some of our data collection tools, some of our approaches were just simply gender blind. And to that end, I think one of the greatest contributions we've made is that sort of conceptual shift. In other words, gender and TB is now properly illuminated, is now part of the discourse. And I think it's very important because men and women are very much related. A lot of the things happening in men's life is because of the women in their lives, and vice versa. Some of the challenges women face is because of the men in their lives. And because we found, for example, female healthcare workers in a very masculine TB program like Nigeria, most of the directors, the program managers, the officers at decision-making level are all men. It was the women, the female healthcare workers on the front line, that directly interface with the patients, that discovered the needs of men. They are the ones that put in extra labor. They are the ones that put in place informal adaptations that was not funded nor guided to ensure that they retain men in care, because they found the additional challenges men faced with adherence and care retention. So I think, we really need to view it a bit more comprehensively. From COVID-19, I take an example from COVID and maybe from mining work. During COVID vaccination, the National Primary Healthcare Development Agency in Nigeria, they are quite active on Twitter. And if you check their Twitter handle, their handle on X rather, they share data on vaccination numbers of COVID-19 vaccines. And I found that in the northern part of the country, women were very few compared to men in the numbers vaccinated. Whilst in the southern part of the country, the men just wouldn't take up the COVID-19 vaccinated. In other words, women dominated the numbers. And I think it's always important that when we think of gender equity, we think of it broadly, across the entire health system. Our services, how they have been shaped historically and at present, and how they are being received. Mining, again, is a profession that is usually put forward as a masculine one, and it is maybe actually dominated by men. But there are certain parts of my country, Nigeria, where female miners make up to 80 to 90% of the mining population. And when I say mining, I mean they engage in rock splitting, they throw dynamite into holes drilled into large rocks, they quarry, they carry trays of rocks And look, the only thing they don't do probably is driving the trucks. But there are a lot of them. And they belong to mining associations, which are led by men. And these women, we don't quite know that their gendered needs are being catered for adequately. Even beyond TB, if you think of the entire pulmonary ecosystem, lung health, chronic lung diseases, how are their needs being addressed in a gender responsive manner? So I think a gender equitable approach is very crucial for health as a whole. And this is how I reflect on my journey, that the skills I've obtained here are transferable to almost every aspect of healthcare, beyond the way we usually think of it. Another advantage I've benefited, just like Jasper mentioned, is the networks I've built. Mentors from all around the world, both the external and country advisory group members, but also the opportunity to contribute to global discourse. I now belong to the Gender Equity Working Group of the Union, through which platform we make input and actually lead the conversations around gender equity. We found the opportunity to contribute to our country's position during the UN high-level meeting and writing up our country's position, contributing to drafting speeches for important dignitaries. And actually, watching how the document evolved to the declaration, I think for me it was a really unique opportunity. Other than that, we also have some pieces of evidence that is out there, that people can look at and sort of draw inspiration. Like in Uganda, gender equity has now made its way into Nigeria's TB strategic plan. It's now its own objective, and it's got work plans, that are now budgeted in that document. And I think in the future, we can pivot on that document to push more scaling of the interventions we have piloted within the LIGHT Consortium.
Let's bring Dr Mohammed Yassin into the conversation. He is an LSTM alumnus and senior advisor on TB at the Global Fund. With his extensive experience in the global TB response and health system strengthening, and as a member also of the LIGHT Consortium External Advisory Group and mentor that Jasper mentioned earlier, he plays a key role in shaping strategies to help accelerate progress towards ending TB. Mohammed, you've heard from Jasper and Ebuka and their growing confidence in the discourse and discussion and leadership in the tuberculosis and more broadly the global health response. Why do you think it's important to nurture and support early career researchers in their journeys?
I believe that supporting and nurturing early career researchers is critical because they can bring new ideas, innovations, energy to tackle infectious disease, including old and new, like TB, and contribute to advancing our understanding of global health dynamics, especially now this has been evolving and getting even more complex. So early career researchers are also the leaders of future innovations and improvement in health service and global and at national level as well. And they are the ones who could contribute to addressing access-related issues and barriers and innovating interventions for infectious disease, tuberculosis, and broader global health. The process of that nurturing and supporting and working with established researchers and academicians and program colleagues would actually ensure that the transitioning of knowledge happens and the skills and experience so that we can make our world better for our future generation. So it's very important to support them, and we see that they have already been contributing a lot.
I think that's really great to pick up on that point, Mohammed, about that transition or translation of knowledge from research to changing policy and strategies, thinking going forwards. And I like the way you phrased it of saying that they bring energy to and ideas. So is that right? Do you have energy, Jasper and Ebuka?
I think I have some left a little after PhD.
That's good to hear. Do you have any advice, Mohammed, on what you'd give to somebody who's starting out on their research career?
Yeah, there are more opportunities and tools to address TB now than ever before. That's not just specific to TB, to other global health related issues. And I believe that contributing to saving lives of millions, especially those who are disproportionately affected and who by infectious disease, and those who have limited access, is really rewarding. And I advise early career researchers to keep asking questions: why, what, and how, as well. Not just to ask questions, but also to contribute to addressing those questions on the how part. That include, how we can address some of the bottlenecks, and then keep being passionate about what you do. And keep innovating and exploring new ways of implementation, new tools that could help to generating evidence and sharing those evidence broadly, so that this could contribute to overall improving access and quality as well. And we are talking about people who may be disproportionately affected, but they may have also gaps in accessing service available. So yes, it's very important that they maintain and strengthen their networks as well, and collaboration, including with their mentors, classroom mates, and colleagues and others. That would help them in their future career as well. I mean, I see that even with my personal experience, having that network, maintaining the network would be critical.
Thanks for that valuable advice. And just turning back to the Light research, from a global perspective, Mohammed, what do you see as Light's biggest achievements over the past 6 years?
I had the opportunity to be part of the Light from the beginning. And I think the main achievement including that the Light promoted partnership and networking, also contributed to capacity building and creating opportunities to early career researchers like Jasper and Ebuka and others, and program staff in the countries as well. So that collaboration with the south to north, including with LSTM senior researchers, it is really one of the achievements. So that what I earlier said, transitioning already happening. So the Light really facilitated that, and I consider this as one of the major achievements. But overall, the Light, the research which you have heard from Jasper and Ebuka, addressing gender-related barriers, including some of the cost-effective elements, and also understanding the gender-related dynamics and the misunderstanding, including of how we understand the TB and gender dynamics, and including implementation of some of the solutions which are not necessarily based on evidence. So the Light already contributing to generating quality research findings, evidence, which fill the gaps. And I believe this inform policy, not only at a national level, but at the global level as well, not just a policy, implementation as well. And I would consider this a major achievement.
Thanks, Mohammed. I'm wondering if we can focus now on you and your journey. You're now working as a senior advisor on TB at the Global Fund. Could you share a little about your journey and what has shaped your career?
I started my career as a physician working in a rural health center in Ethiopia, where infectious disease, including tuberculosis, malaria, and others, were the major hurdles, causing mortalities and many people dying of this infectious disease. And I have seen, how people struggle to receive the service, including for TB, which my center was one of the 3 pilot dot center in Ethiopia for the whole country and covering millions of people. I know how people really struggle to get the diagnosis, treatment of TB, including all these socioeconomic constraints. And as TB is a disease of poverty among even poor people, and all the stigma and access-related challenge. So that really shaped my career, and I decided to really contribute towards more broader public health than diagnosing and treating individual patient, and addressing some of the bottlenecks that contributing towards our understanding of the overall epidemiology of this infectious disease, and designing and implementing a more problem-oriented research and implementation projects which contribute to improving the coverage and quality as well, addressing some of the bottlenecks which disproportionately affect people with TB, including the poor people who may not afford to access. That really shaped my career, and I had opportunity also to lead a regional state-level TB, HIV, and communicable disease program where I expanded the service massively throughout the region. Joining LSTM, studying and working at LSTM as well further enriching my skills, experience, and expertise. A great opportunity to meet my mentors, teachers, and also work with others in the countries as part of multi-country collaborative projects, including in Nigeria, Ethiopia, Yemen, Nepal, and Brazil, which contributed to further advance my skills and understanding, but also continue contributing toward this, conducting research projects which really contribute toward this addressing gaps. And I had the opportunity also to create academic links between LSTM and universities in Ethiopia and Nigeria. All this contributes toward that dream of improving access to people who are struggling to access those basic services. Then I had the opportunity to join the Global Fund 15 years ago. That's a critical milestone for me, as a Global Fund is a major source of funding for TB, HIV, malaria, and community and health system strengthening. Joining Global Fund means actually broader opportunity to contribute toward this movement and be part of it, and work together with the national TB programs in many countries, technical experts at the global, regional, and country levels, researchers and organizations addressing different aspects of TB, including private sector and communities. I had the opportunity also to work with not only TB, HIV, but on antimicrobial resistance and COVID response. And all my experience as a physician, researcher, global health professionals helped me to, when we had interactions and discussion, when I support programs and Global Fund teams, so that whatever advice I provide are actually based on evidence, as I always keep updating myself that things are moving quickly and advancing. And all those helped me in advising relevant teams on a strategic investment of resource and cost-effective approach, and accelerating uptake of new tools, innovation, and maximizing impact. Always promote innovations and being updated, and work with early career researchers and established researchers as well at different level. And my engagement with lights is part of that interest and passion, and I enjoy what I'm doing. But I believe that I'm contributing to what I initially decided to contribute to, that is improving the access to basic service without incurring any cost, any hurdle, and then accelerating towards ending those infectious diseases which are curable, treatable, and also contributing toward this global health in general.
It's been really inspiring to hear the passion from all three of you of those who now work at LSTM and who have worked at LSTM for increasing access to services by ensuring that we reach everyone. And that has come through really strongly. And it's been lovely that we have these connections and collaborations going on through the wider LSTM family. And I hope, Ebuka and Jasper, you'll take that going forwards as your careers develop. To close, I'd love to go around all three of you and just ask you to give one or two key points that you'd like our listeners to take away from this podcast today. Mohammed, over to you first.
Yeah, thank you very much. I think this is it's a great opportunity. I see how the LSTM, the Light Consortium in general, contributing toward this generating evidence and informing policy at all level. But that generating evidence is also based on that partnership, and as Ebuka mentioned, co-creating of some of the solutions and early engagement of relevant stakeholders, including national TB programs, and we have already facilitating, the uptake of any of the recommendations and findings, and the buy-in happening early. And I really like the way the whole projects are being designed as more problem and solution oriented, more consultative and collaborative approach, and in the meantime fostering partnership and learning from each other, but also solving some of the problems, including our misunderstanding or understanding of all the TB and gender dynamics and issues related to equity. And overall, the contribution to this generating evidence would help to moving more to people-centered approach, a more cost-effective implementation. And I'm happy to hear that we are talking about integration as well, not just TB, but broader people-centered approach. We shouldn't miss opportunity. And I like that the way we are talking about cost effectiveness, because we know that probably there may not be enough resource to implement everything everywhere. And while it's good to see that we are focusing on men and TB, that's overall we understand that from the epidemiology, but we are not also overlooking or ignoring the women and girls as well, where access-related issue barriers are still there. But overall, about informing our policy and strategy by data evidence and then partnership, as we all breathe the same air when it comes to TB and other airborne infectious disease, we all should take our share and responsibility and synergize our efforts toward this accelerating ending TB.
My closing reflections are really, I come from a medical background, so it's really going beyond just biomedical approaches and really critically thinking about the social determinants of health, because these are the drivers of inequality, both in that TB burden, TB treatment outcome, across the entire spectrum, even exposure and risks of developing infections. So gender has been a very important entry point for me into this area. And I hope to build further work, that really focuses on looking at social determinants of health and how this can be used to improve care for TB and other infectious diseases.
I think I've learned that when we build trust, invest resources and time to build trust with communities, we then repeat when we need their cooperation. For example, maybe during a pandemic or in leading a health intervention. And I found that a community-led activity is more likely to be acceptable than the one we lead as a system. And then putting people right at the center, the community understands it better than us. So overall, I think it's just an encouragement that, look, we've started the journey towards people-centered care, but we've not reached our destination yet. So we keep pushing the conversation in that direction and hoping to attract more resources to engage communities, to lead the care and improve access to everyone, everywhere.
Thank you all for joining us today and sharing your reflections and valuable insights. Don't forget to follow the LSTM in Conversation podcast wherever you are listening out there, so you don't miss an episode. And if you enjoyed the episode today, please do share with your colleagues. The more people who hear these stories, the bigger impact we can make together. Thanks again for listening, and see you next time.